Welcome to the Ketamine CME. This is Dr. Barbara. May the fourth be with you all. So my first interactions with ketamine was in my college days in upstate New York, hearing that people had taken "quote unquote" Special K, and then the neighborhood friend says, "Well, it's a horse tranquilizer," and you say, "Oh, that's something that I don't want to use." But ketamine is essentially in a class of its own. And there are some people who are very afraid of it. There are some people who are very for it. And I think I'm in the camp of the right tool makes the job go easier, but using the wrong tool for that job is a sign of a poor craftsman. So ketamine has great indications. There's other situations where ketamine doesn't belong, and when it's used it may end up not doing well, and we'll get into some of those cases later. Does anyone know where ketamine comes from? It's a derivative of. Just throw it in the chat there. Ketamine is actually a derivative of something that's illicit. Is it a benzo? Is it an opiate? Is it a sedative? It's a little bit of all three. Ketamine is, Paul D says it, it's a derivative of PCP. Yes, ketamine is a derivative of phencyclidine, a potent hallucinogenic. Also no firsthand experience with said PCP. But Catherine McGeary says the same. That's great. But it's not a medicine that is like anything else. ACEP, the American College of Emergency Physicians, came out with a classification for it in their policies. It's a dissociative amnestic. Okay, what does that mean? It's literally, I wish we were on video for this bit, but it's literally taking your cortex out. For another movie reference, there was that movie with Nicolas Cage, Face Off. He goes, "I'm going to take his face off." Well, this is taking your personality off. It allows the person to maintain their protective airway reflexes and spontaneous respirations, but they're literally unaware of anything going on around them. Okay, so what it does and where its unique utility is it's not going to drop your hemodynamics similar to other sedatives or sedative hypnotics. So, like battlefield surgeries and other types of procedures where they, get someone liquored up because they're going to do some amputation or something like that, or, other types of sedative hypnotic use to facilitate a procedure, you can overcompensate and cause someone to become apneic, hypotensive, bradycardic, things like that. Ketamine does not create those same problems, and it allows for procedural facilitation or calming, to say the least, medications to be given while the patient's completely unaware of it. And I've used it a couple hundred times, and it definitely has a unique way about it. There's nothing to describe. It's nothing like it with regards to propofol or Valium or Versed or anything else like that, where the person is awake, but almost like in a trance, right? And what it does is it disconnects the thalamocortical and limbic systems from these outside stimuli. So like eyes, ears, nose, things that you're sensing, you're not able to process them and move, react to them. So that's all interesting. Any questions on how the pharmacokinetics, the mechanism of action is on ketamine? All right, just throw them in. I'll come back to them. I do want to move on because it's a lot of people here. But most importantly, awake, trance-like, protective airway reflexes still intact. Key. Well, how's it different? It's not as dose dependent as other meds are. And for those of you who are familiar with the 10 of Versed, that 95-pound octogenarian, and protocol says 10 of Versed, and then bring them in comatose and bagging them. This medicine really doesn't have that same dose-dependent characteristics. So essentially, that's why that K with the parabola is really a neat concept, because once you're above dissociated state, it really doesn't do too much else, which works out well when you're thinking about procedural sedation in the emergency department or some sort of pain control or other pieces. Once they're dissociated, you really can't dissociate anymore. Um, Propofol will kill you in excess, right? We learned that famously with the Michael Jackson case. Versed, Valium, other benzos, less likely to kill you, but definitely can create some situations that are bad for the patient. So you don't want to do that. So at the lower doses, you have the analgesic component, the recreational and partially dissociated component, and then like the fully dissociated component. But the likelihood of increasing ventilatory depression doesn't happen with this. Okay, so this position piece, the quantity of ketamine administered has no clinically important effect on airway integrity and respirations within the range of clinically administered doses using standard administration methods. Okay, so that makes it perfect, right? It's not. There definitely are situations where too much ketamine can get you in trouble, but Kevin, good question. Kevin brings up cannot overdose. You can't over dissociate them, but you can hurt them. And I'll get into how you can hurt them as a piece of this, because, for those of you who may look at other literature, New York City is a little late to the ketamine game. And I think that that's for good reason. And the initial studies on ketamine and EMS were, a higher dose. And there was a lot of issues with that, specifically laryngospasm and crash intubations, which is why when we wrote the revamped excited delirium protocol, typed on the same computer I'm talking to you guys on right now, we pushed for a lower limit of ketamine to enhance safety, and specifically because we had other medications in our armamentarium. So you can hurt someone with too much ketamine, but you cannot over dissociate someone. Brian has a question there about ketamine and the benzos. We'll talk about that in a bit, Brian. That's definitely going to come up. Okay, so with regards to timing, similar to, the benzodiazepines, which you give on a 5-minute interval, a nitroglycerin, a 5-minute interval, or an infusion like dopamine or norepinephrine, you can kind of hit them once and be done with it with ketamine, because it's working in a different way than medications typically work. So you once you're in the ketamine dissociated state, colloquially known as the K-hole, but once you're in that dissociated state, you only need additional dosing to keep you there. You don't need to. They're going to come when they come out of it. They come out of it, but you don't need to keep a continuous infusion of ketamine, which I've seen some of these PCRs or people on ketamine infusions. I don't know. We really don't do that, but that's fine. So Jacini asks, how would you need that additional dosing? It depends. The mechanism of action, the duration of action, I have them later in the chat, in the slides. I do typically use ketamine in conjunction with other medications, so it's tough to say specifically when they wake up, but it's kind of like a 5 to 15-minute thing, but could be different if someone's a ketamine user, if they're sensitized to it or not. And again, as I've gotten older in my life, the biggest clinical thing I can tell anyone who's in medicine is every patient is unique. So it depends. But we've worked out all the details in our indications for those of you who are going to be administering phencyclidine derivatives to people in the streets of New York. So Remac indications of ketamine, and I got this from a redundant number of people because it seems that the protocols are always in flux. So we have four and a half ish protocols for ketamine. We have the excited delirium, medical control option, adult and peds, and that's 2 to 4, 1 to 2. 2 to 4 IM, 1 to 2 IN. Being a productive member of the protocol committee, I feel that IN, intranasal, should be treated more with intravenous administration. So, but there are some times where the IM and the IN dose is equivalent, which is confusing. But just know that intramuscular dose is 2 to 4, which is lower than most regions have. Most regions have 3 to 5 milligrams per kilogram, and they get into trouble with it. And the intranasal is 1 to 2, so half dose. Okay. The general pain is a fraction of that. And I probably should have, I think I did on the next slide, but probably should have inverted those two bullet points. The intramuscular / intranasal is 0.4 for pain. And the intravenous for pain, adult or peds, medical control option is 0.2 milligrams per kilogram, max of 25. Again, these are a lot of numbers being thrown at you. I'm sure, quote unquote, there's an app for that. I don't recommend any particular apps. I recommend because this is a new thing, and I would make every effort to commit this to memory. Okay. Chris Klein has a question. I'm going to get to it in a second, Chris. Procedural sedation, 1 milligrams per kilogram IV, max 100. And that's going to be for your airway management or potentially even for pacing. I could see it for, but I have to see where that procedural sedation standing order is being worked in. I assume that's going to be more of a GOP overarching piece for airway management / cardioversion. I don't know about the pacing versus cardioversion discrepancy extending. Ketamine should be long enough to pace someone on, but I would defer to the REMAC and the protocol committee on exactly how they're going to parse that out, because any port in the storm for me, but ultimately they'll probably say which one you can use it for. Intubation, standing order, 2 milligrams per kilogram IV, max of 200, and post-intubation sedation, 1 milligram per kilogram IV, max of 100. So you have it in for a bunch of different places there. Chris said about the 2 milligram versus the 4 milligram. Okay, great question. And it's funny because Chris, you hit up on a point I'm going to touch in one of the later slides. I just say the dose. Implementing it is someone else's job, right? So paramedics are in a unique position where you're both the executor and the operational person to make it happen. So if someone is not suitable for a needle in the thigh, I would lean towards the nasal dose. If someone was not suitable for a intranasal atomizer, I would lean towards the intramuscular dose. So you also, depending on the dose and the weight of the patient, do I have enough to get intramuscular in? Or am I going to just give intranasal? If the person is, 200 kilograms, do I have that full 400? But these are operational concerns, which I would manage in the situation with my options. I don't think it's a specific one way or another. I hope that answers your question, Chris. Oh, Staley says, I do. Yeah, I would take the weight and see what number works best for your dose. So if they got 3 milligrams per kilogram, because that was an easy number to administer, I think I'd be okay with that. So I would look at the high, look at the low, and say, what can I achieve with the medication I have? If it's, 500 milligrams per 5 ml, and the person weighs 100 kilograms, I need 300 milligrams. So that would be 3 mLs. if I want, if I want, I don't think it's, I think you would maybe also go low dose for someone who's moderately agitated or moderately agitated, and go higher dose for someone who's severely agitated. Take into consideration also co-ingestants. There is some discussion about people with existing psychiatric disease not getting ketamine. Yes, Chris, I'm not thrilled with weight-based doses weight-based doses in a range. I'm not thrilled with that either. But this is what was passed, and this is what I'm telling you about. I think you'd have to identify what's a case-based situation. But we could take this offline. I don't want to go too much time on this. I think it's clinical judgment to say you're going to give the high dose or the low dose. Okay. But that's good. I mean, we are talking about this. So I did break these down one by one in the indications, but this is the patient that I don't think you want to get caught with the photo on, right? 4 people, face down, knees in the back, hog-tied, right? Not a good look. Just not a good look. So we want to have both chemical and physical restraint going on for this type of patient. If those of you had medical control calls with me or any in-person interactions, I will not put restraints on a patient without sedation, ever. And the reason why I won't do that is if you come and strap me down, you're going to need to sedate me. So if you're going to hold someone, it's humane and appropriate to put medications in their system to help them be better handling of the restraint you're about to provide to them for their own safety or for your safety. This is, like I said, this is a bad look. 2 to 4, I agree, Chris. It's a good point about the dose range. I think if you take into consideration the specifics of the case, there are some components of male gender requiring higher doses, co-ingestants, other things like that might be the best way to go about it. You could also start low and re-administer as needed. But we would all most likely say you can't take a medicine back. But once, like with specific to ketamine, once they dissociate, it's just time to undissociate them. And there is no antidote. There's no, flumazenil for ketamine. There's only clocks turning for ketamine. Pain. Ketamine's big for pain now. There's actually, people have these like ketamine clinics that do them for migraines and headaches. And, the dose is very similar, 0.4, it's half the dose for the IV. But here you have the IM and the IN together, where they didn't have the IM and the IN together. I got a few friends who work on that REMAC exam. This is not the type of stuff that we need to get people failing for. Don't focus on like this is going to be like the reason why you pass the MAC or not. I think understanding there's a difference in delivery dose is more important than excited delirium, muscular and nasal are different doses. Pain, muscular and nasal are the same dose. That's not where we want. That's not medicine. That's memorization. So just understand that there's different doses. Have your own reference points, and this is going to be a medical control option. You're going to be getting the dose from the doc anyway. So that's that. Any questions on pain? No, good. And it goes back to that K thing there, the ketamine continuum. That 10 to 30, it's somewhere between the pain receptors and the partial dissociation. Kevin asked a question about excited delirium, where you would add on. I think if you've given the IM Versed and they're not sedated, ketamine is a great choice. There is anecdotal experience coming out of one of the poison centers in the city that, everyone who gets ketamine is snowed and they're getting intubated. And I would say, I spoke to some crew members, but the feedback is that they're snowed because the Versed snowed them. So I think it's great to add on. I think the better thing would have that dose of Versed be halved. Okay, moving on. I love this picture. Okay, I want you to see this now. Now I know procedural sedation is the adult piece, but I want you to look at these 3 photos of this very, very, very happy child having, dental work done. And they actually, when I Googled ketamine, this kid came up because there's some dentists out there sedating children to do dental work. I can't know. Chris, I'll get there with the hypersalivation. So please look at the photo in the lower left and this very excited child having his cavities checked. And then, and they're in, the dental hygienist or the dentist is actually in there doing the work. And then the kid in the middle is like, I don't know if I like this stuff. I got to move my tongue. What's going on here? And then that kid with the orange halo that is just zonked. Those are ketamine eyes. That's the kid that's, they've had a little fasciculations. You may see a little fluttering in the eyelids. And then it's this, whoa, strange stance. So that way, now the dentist is in the mouth, the kid has no idea. That's what I want you to think about with ketamine. That kind of stoned stance, a facial expression, for lack of a better word. Sorry for the colloquialism, but that's how ketamine patients look. For procedural sedation, we're going 1 milligram per kilogram IV. I would double check this. I guess this is for cardioversion and pacing. Potentially, there may be some expansion here with maybe splint application or other painful procedures, maybe IO administration. But I guess REMAC is revamping the whole cardioversion / pacing into a procedural sedation piece. So this may be, hot off the presses because it appears to be distinct from intubation. I'm going to get through indications, then I'm going to hit the chat. We'll take a quick brief. Intubation, 2 milligrams per kilogram IV, max of 200. Post-intubation sedation, again, once it's associated, 1 milligram per kilogram IV. And it's more that titration piece. And if it's for peds, yeah, it's a medical control option. So you do have standing order, intubation, ketamine dosing. Woo, yay, closer to RSI. And I love this photo. If you think about it, that's the last thing some people have seen from the airway being placed. So hypersalivation, Chris says, we're going to talk about adverse effects, Mr. Foote, and it's actually very rare. But I would rather you just manage the airway, basic maneuvers, suction, things like that, NPA, OPA. I don't think atropine, this is potentially a polysubstance using person. You're going to start mixing the soup a little too much here. Bradycardia, okay, I could see that. But if you're considering hypersalivation, calling for atropine, I would just call and talk to the physician. Okay, that's because we can't protocolize everything. Oh, Paul, you're killing me with this ketamine dirty drip thing. We're skipping that. We're not going to go there. And Jacob, I don't understand what you're trying to say. Okay, for the very anxious patient, low. Okay, go ahead, Jacob, talk. Bring it on.
In my conversations with telemetry, for someone who is not a very clear excited delirium, the threatening, hyperthermic, very clear excited delirium patient, the more anxious patient who just really needs to kind of chill out for us to be able to address their care, they've just said that falls into excited delirium, give them tenofovir, which is more than I think that they should have, but, doctor's orders. Do you think that ketamine would be a good option for those people who may benefit from like the 2 to 3 of Versed versus?
Yes.
Okay, thank you.
Yes, yes. I think it's worthwhile to say they're an excited delirium person, but I think the standing orders would be dangerous, and I'm calling for discretionary decisions. What do you think, doc? I wouldn't say I want to give 5 of ketamine to this person. I would present it as the standing order that's on paper is a danger to this patient I have, and I'd like to modify with a game time decision. Okay. The dirty ketamine drip, Paul, will get there by 2030. All right. So let's do some anecdotes. Yay, story time. Anybody have a question so far? Besides, I mean, I think we're dealing well with the real time chat. So I'd like to just keep going. If we need to pause and take a break, let me know. Okay, so I did a ketamine search. In other words, Dave Ebert sent me 50 PCRs, and I looked into most of them. And I wanted to kind of hit up where we were doing ketamine care in Northwell to date. So we have a 22-year-old male at a standalone ER going to the MICU for excited delirium from polysubstance abuse. This patient, ketamine and propofol, GCS of 3. The vitals were normal, the vent was normal, and the patient seemed to be, copacetic for the transit. Essentially, magic, right? Nothing. This is a disaster patient, who, in years past is either hypotensive and needs an airway emergently, and now this person, the airway pressures are fine, the vitals are fine, the patient's literally on pause, which is perfect. Another one is 60-year-old female at a network hospital post arrest. With dissection, and she's going for CT surgery. I mean, this is like a shoot the moon type of job here. Post-intubation sedation was ketamine. The patient woke up, needed 4 points, and then like in the middle of the transit, fentanyl for medical control. So the patient did not have that prolonged sedation, as Justini had said about how long do you redose. I guess no one redosed the patient, or the patient didn't have sedation for the duration of the trip. But the person was hypotensive tachycardic pre, the person was hypotensive and tachycardic post. In that kind of case, as Brian Hildebrand hinted about before with the paralyzed without sedation, I would have just paralyzed this person. I mean, every time I'm transferring someone like this who has where a change in their sympathomimetic surge can actually kill them, especially things like a dissection. We can manage the blood pressure as much as we want. If you don't manage the awakeness of the patient, it could be disastrous. So ketamine alone for sedation for this trip is probably a bad move. But I can understand the person was hypotensive. I've had people like that before, GI bleed transfers, things like that, where their vitals are hemodynamically unstable. You can do everything you can with ketamine, but I'd rather they be ketamine paralyzed versus ketamine propofol, and potentially and become hypotensive, apneic, or become ketamine alone and wake up. So as much as I don't want people waking up, I don't want to paralyze anyone who's potentially partially sedated. This is an incredibly complex job that waking her up is definitely bad. The other one was an 18-month-old male with an out of hospital network going to a high level of care for bronchiolitis and respiratory failure. This kid had like tachycardia 150, 160. That's still a little fast for a 2-year-old, but the ketamine had the child in, they mentioned P for just pain. They didn't have a full GCS, but the BP was normal. The kid did not require vasopressors. I mean, the child, with essentially the fight of its life going on, and ketamine treated this child well. That's another thing about ketamine is it's a good choice for both adult and kids. And then the last one was traumatic arrest at a community hospital, 30-year-old male. And this guy was, again, the mortality rate in this person was like 70 to 80%, but significant multi-organ injury, totally, pedestrian struck, multiple injuries, multiple long bone fractures, multiple solid organ injuries, and massive transfusion protocol. And the docs at the community center put the patient on norepi and ketamine. I guess as an infusion, I can go back, but essentially because anything else would have been hemodynamically unsuitable. So here you have cardiothoracic disaster, polysubstance, just brain stuff without, with minimal impact on vitals and able to take the kid down perfectly. The baby on, respiratory, impending respiratory death, and a mangled trauma patient, and ketamine's available for all four. So I thought this was a good spectrum of 4 different cases where you rarely see the same medicine 4 times in these 4 patient populations. I'm not going to go into all details about these cases. That's essentially the extent of the physician-directed call review piece of this, because I don't think that's relevant. I'd want to talk more about the medicine than in these specific cases, okay? Because there's too many confounders. Situational issues. So we got the situation and the situation room there with Wolf. So for, I guess it was, I don't know if it was a question it was earlier, but, we watch these movies and, or any type of command situation, an ACLS code or something, and the code leader just says, make this happen. And it's like, okay, sure. Yeah. Do you know how to operationalize that? And for once, I just like Spock or someone else to turn around and go, can you actually think about how tough it is to do what you just said so quickly? Yeah, sure. We'll replace the arc reactor and the thing. You're just sitting in that chair saying, do it. Ketamine is one of those drugs where saying it and doing it are 2 different things. And I cannot stress the importance of a new medicine that you're unfamiliar with, and the dose ranges. Never had 4 or 5 different indications for a new med. It was norepi, think about the most recent meds we added, right? Norepi. It was really shock is shock is shock, right? We have multiple ranges, as Chris Klein points out, dose ranges and a variety of indications, both adult and peds. So when you're going to deploy this, the decision to deploy it has to come, 20% decision to do it and 80% how am I going to do this, right? Because the logistical piece of operationalizing the executed order can be where you get into trouble. Okay, so thinking about orders versus execution. If you Google ketamine, there's a lot of different concentrations. And once that little plastic piece pops off, you don't know what dose you have in your hand, because they put a different cap on the top, so this is the 1,000 per 10. But once you flip that, no one knows. Oh, Tara, I didn't have a good Star Wars picture for that. There's no one executing stuff. I didn't even think about that, but good point. Long story short, 500 per 10, 50 mgs per mil. 1,000 per 10, 100 per mil. 200 per 20, 10 per mil. What are we doing here, guys? So my favorite medical show growing up was always Scrubs. And it's like, don't tell me what amount to give, just tell me what dose you want, because all of it is relevant to the dose. But remember that, the doc is making the order and the nurse is the one implementing it. And that's actually a safety check. Nurses have saved me by saying, you sure you want 20 units per kilogram of insulin? Because that's a dose that'll kill people. And I say, no, PA put the order in wrong. What are we doing here? So you are both of those people. What we have in our system is 500 per 5, which is actually a relatively high concentration compared to what those other ones were, right? Looking at 50 per mil, 10 per mil, 100 per mil. We have the 100 per mil. So those of you who have kids in grade school, if you do the greatest common factor and you're a math genius, 500 per 5 is actually 100 per 1. So let's just think about 100 per 1. So ketamine, that's about as much ketamine as you want to give to anyone, right? From some of the literature searches and other, anecdotal experience, more than 300 of ketamine is a danger to a patient. Okay. And with our concentrations, that's about as high as you would, the largest syringe there that you would want. Any questions on that? If you're pulling up a 10 cc syringe, you're in trouble. It would be safer to consider using an insulin syringe or a 1 ml syringe, but I can't say we're going to use them, nor do I want to confuse anyone. But a 3 ml syringe is something we're all familiar with, and that's about the max we would want to give. Okay? Side effects. You're not going to turn into a horse, although this was used for horses. So I am not in this kind of lifestyle, but I do pay attention to what goes on around me. And having worked in Brooklyn and other parts of the city and whatnot, nothing seems to happen to these people. You know, like we talk about the safety of certain medications, you know, EpiPens. Everyone's like, oh, their heart's going to explode. You got to put them on a monitor. You know, if someone has an allergic reaction, park rangers using EpiPens off monitor with a 4-hour egress in the middle of like Yosemite. Nothing happens. These people at these raves, it's not the monitoring because they don't have any. It's not the fact that they're walking around with IV fluid bags. They're not. It's not a calm, safe, limited interaction environment at all. But, you know, people at these types of festivals, they use this medicine recreationally and with limited dosing ranges. And there's really not many case reports of like, you know, a rave and everybody dying. And I know it's a young population, but that's really, there's not a lot of case reports on this stuff. Side effects, someone had mentioned the hypersalivation. I will tell you, every time I give someone ketamine, I think of that individual doing this for the first time. And for whatever reason, this is not an elective procedure. You dislocated your shoulder. I'm putting your hip back in. We're doing a laceration repair or something. That person's not thinking good things. And that's where you get into this emergence reaction. I have yet to have someone have an emergence reaction to ketamine. And I'll walk into the room and I'll tell them, you're going to feel some abnormal stuff. You're going to feel an abnormal sensation. You're going to have stimuli that's unique. It's okay. We're here with you. We're monitoring you. We're going to keep you on our heart device, our heart monitor, our oxygen monitor. The medicine, you know, will wear off, and we're going to, you know, we can stop at any time. And I set them at ease, and I tell them to think happy thoughts. I tell them, like Peter Pan you had to think happy thoughts and you'll fly. Well, if you tell someone this is going to be terrible, we got to do this thing, we're going to reduce your shoulder, it's probably going to hurt, when we're done, we're going to put you, that's not going to work. That's how people get emergence reactions. So I think my prep talk to them is actually very useful. And I also do co-administer some benzodiazepines, which has been shown to reduce emergence reactions, as Brian Hildebrand mentioned. But the most common side effects are vomiting, hypertension, emergence, hypoxia, and laryngospasm. You don't see too much hypersalivation. That's kind of been debunked. Laryngospasm is a kill. So if someone is excited delirium and goes and has laryngospasm, you're going to need to intubate them. And if you don't intubate them, they'll die. And that's the danger of the other systems with the higher dose ketamine. For whatever reason, these 300, 400, 500 milligram doses of ketamine seem to have a little bit more rates of laryngospasm. So in your practice, taking an excited delirium patient, telling them, just calm down and think of Disney, probably not going to work. I get that. My indications are different than yours, but if it was pain, you could definitely talk to the person. If it was some sort of sedation for a cardioversion, definitely talk to the person. But maybe that's a reason to start lower on the dose for the excited delirium patient and see how it affects. And we can talk about it later. Again, medicine's in evolution. It's always in motion. But I've had good clinical experience not slamming them with ketamine and saying, "See you in the K-hole. Tell me when you come out." It's time to talk about Peter Pan, not Cinderella. No, Alice in Wonderland. I'm sorry, Alice in Wonderland. Speaking of which, physician use. I love that's from Spies Like Us. I love that picture because they don't know where they're doing. They're pretending to be doctors. We have something called Ketafol. Ketafol is a portmanteau, just like a spork, a word made up of two things. But we use both ketamine and propofol. And ketamine and propofol, this was like the big hit when I just got out of residency. It was like, oh, ketafol for this, ketafol for that. What ketafol does is it's half ketamine, half propofol, and it's like peanut butter and chocolate. They're just meant to go together. It's one of the most perfect symbiotic relationships outside of the clownfish and the anemone. Ketamine, a little bit slower onset, about a minute or so. Propofol, a little quicker onset. Propofol will make you apneic. Ketamine will take care of your airway reflexes. Propofol sucks for analgesia. Ketamine has analgesic properties. Ketamine might raise your blood pressure with limited clinical significance, but the numbers do go higher. People don't stroke out, but their numbers will go higher. Propofol does the opposite of that. Ketamine will raise your heart rate. Propofol will make it a little lower. Propofol is euphoric. It makes you feel very, very good. Ketamine has an emergence reaction. Propofol will combat that. Ketamine gives you sensory phenomena. Propofol makes you forget all that stuff. So what they used to do was to take propofol and ketamine and put it in the same syringe. That's not the way I do it. Much like most other things in my clinical practice, I don't just follow the leaders there. Jaseni, you mentioned the duration. I didn't know it off the top of my head, but an IM dose looks like 12 to 25 minutes. Okay. And for those of you with the IV doses, maybe critical care management, it looks like a redose might need to be done every time you do your vitals, but that's kind of the same rehash. So I'm going to go for the blog post from Rebel EM, the Salam Rezai's website. So it says, how do you mix ketofol? And then there's whole diatribe. I'm going to just read it. There's no standard dosing regimen established, but most studies and authors recommend a 1-to-1 ratio. These medicines can be given mixed or given sequentially. Okay. Imagine you want to take the peanut butter out of that bowl, right? You can't take the peanut butter out of that mix anymore. So he talks more about this podcast guy who says something about ketofol dosing. And then he says, the regimen is fairly simple. I want to see how simple you all think this is. It comes in a 50 milligram per milliliter concentration. So if you take a 10 ml saline flush and empty 2 mLs and draw up 2 mils of ketamine, you have 100 milligrams of ketamine. Immediately not simple. There you go. Propofol comes in a standard 10 per 10 concentration. So fill up a 10 ml syringe of this, so you have 100 milligrams of propofol. Okay, that's simple. Mix the two in a new 20 or 30 ml syringe, which is the size of a carrot, and you get 100 milligrams of ketamine, 100 milligrams of propofol, and 200 milligrams total. Every 1 ml has 10 milligrams of ketofol, a made-up drug that you just created. Your starting dose will be 0.5 mg per kg, followed by another 0.5 mg per kg every 30 seconds, and then maintenance every 25 milligrams, 0.25 mg per kg as needed. That is not how I do this. And I think that's disastrous, going back to the Fishman corollary, which is every patient is unique. So if you do that for a chronic alcoholic, they're not going to get enough propofol because their if they're habitual users, they're going to be tolerant to the GABAergic med. And if you do that to someone who's a little on the anxious side, they're not going to get enough ketamine. And we just said one of these medicines drops your blood pressure, and one of these medicines raises your blood pressure, and one of these medicines is better for your airway, and one of these medicines makes you stop breathing. So the way I do it, I am not a magician. I am not David Blaine. I am not going to, the key about David Blaine to me is he does that stuff 10,000 times before he goes on the street and throws cards at a wall and come out, ablaze on the other side. What seems spectacular is just tons and tons and tons and tons of repetition. That's why he's so amazing at it. I don't want to find out my little magic trick didn't work the first time. So first of all, I don't care how long the sedation takes. When I give ketamine, safety of the patient is priority one. Nobody touches my table. I get a little tray table and I stand there. I get all the end vitals monitoring and all the other hemodynamic stuff. I just say thanks EMS because we were doing this first in EMS. The hospital came on and said, oh, it looks like we prevent people from dying from oversedation if we use end-tidal CO2. So I've been using end-tidal my whole career because of what I learned as an EMS fellow a decade ago. Very simply, I get the ketamine from the nurse, I check the concentration, and I figure out what 50 milligrams is. Because when the pharmacy changes their concentration, invariably, I'm dependent on what the person gets. I'm not going to say, I usually give 2 ml. Nope, not for me. I want to know I'm giving 50 milligrams. I keep that in a syringe and I keep it near the ketamine bottle. So I have one syringe filled with ketamine near the ketamine vial. I get the propofol. I put in a 10 ml syringe and I keep it near the propofol bottle. Propofol is, milky white. It looks different. So I know I have 2 different medicines. Then I look at the vital signs and I make a game time decision. I start with about 50 milligrams of ketamine first, and then somewhere between 30 to 50 milligrams of propofol, which can be usually like 1 ml of ketamine or 0.5 ml of ketamine, depending on the concentration we have, and about 3 to 5 mLs of propofol. After that, I see where they go. If their blood pressure goes up, they get more propofol. If they become somnolent too quickly or their sats drop, they get ketamine. If I need to wake them up, I use a nasal or I press on what hurts. And knock on wood, I've had no issues with that. I have had people say some really, really funny stuff when they're under, most of which will not be on this recorded tape. None of which will be on this recorded tape. But people will get very dissociated. And I talk to them. I talk to them about their grandkids. I talk to them about their family. I tell them to go find their own beach. Think about Coronas on the lounge chair, and then they go to sleep. And then we do what we have to do, and then I let them wake up and I post monitor them. But that's how I use ketamine. I usually end up giving about 100 to 200 of ketamine and about 100 of propofol, mostly because I'd rather they be more dissociated than more apneic. But that's about my experience giving ketamine. And I'm giving it controlled fashion in an IV, not lawn darting them in their arm with 300 milligrams. Dave asks, how much more of each would I give? Usually between 25 to 50 aliquots, maybe 50 to 100. I'm cheap on sedations. I definitely don't want to take them down too fast because there's no reversal drug for either of these. So there's people who just slug them with 100 of propofol and 100 of ketamine and see what happens. I'm too old to go back to court. I'll leave it at that. I'd rather sedation take a little longer and the patient was safer. So some journal studies, and we're coming to the end here, and then we're going to take questions. Here we have one journal study, rescue intubation in the ED after pre-hospital administration of ketamine. So here's a retrospective cohort study, which means we looked at the charts after things happened. Cohort means that it's all patients who had something, one thing individual that happened to them. Right now, you're all in a cohort of this class. So it's looking back at charts of people who got ketamine. We made a change, we gave them ketamine, and then we're going to look back and see what happens. This is not ongoing quality. This is retrospective chart review. They were taking the two community EDs. Over 2+ years, 86 patients got ketamine. So not a lot of ketamine administrations overall. That's, that's like one patient every month, right? 28 months. No, it's like 3 patients a month. That's not enough usage to say that we're doing something with alacrity, right? 14 underwent endotracheal intubation. Patients with a higher temp and a lower GCS were more likely to require intubation. That was just their what they found. No age or dose-dependent association on intubation rate. Intubated patients averaged about 39 years versus 44. Really inconsequential. The mean ketamine dose was 340 milligrams in the people who were intubated versus 350 in the patients not. To me, that means nothing. The people who didn't get intubated got more ketamine. But still, that number is high. So I would say this is a system that's given a little too much ketamine based on their dose range. And their mean weight-based dose ketamine was 4.44 mg per kg in people intubated versus 4.96 in patients not. So you actually got a higher dose of ketamine in the people not intubated. So you can't, again, it goes back to the once you're dissociated, you're dissociated. They did say in this paper that provider decision had a lot to do with who got intubated. So to me, this whole paper about intubation and ketamine means that when Dr. Thompson works his or her shift and someone comes in with ketamine, they always intubate them. It's 3 times a month. This is literature that doesn't tell us anything. Does that make any sense to everyone? About 1 in 6 people get 1 in 8 people get intubated if they get ketamine. Has nothing to do with the dose or the weight-based dose. Again, doesn't help us as we move forward. This is from 2000 this year. Moving on. This is another study. Intubation of profoundly agitated patients treated with pre-hospital ketamine. Again, retrospective cohort study. All patients who received pre-hospital ketamine, control of profound agitation, and then were transported to an urban level 1 trauma center, as opposed to community EDs. 2.5 years worth of cases, and in those 2.5 years, again, 227 times. So we tripled the number of people getting ketamine, and 135 had the ability to do this study, which is really a shame that you lose half of your cases. So again, when the literature publishes this and they have a conclusion, imagine if I read the paper and just skipped every other page and said, oh, I understand this study. So they lost half their patients. So they intubated 63% of this 135. 4 of the cases were pre-hospital intubation and 2 people died. And I guarantee you those were the ketamine laryngospasm, that 1%, as noted in the study earlier. And then you have some very curious associations when they do these post hoc univariate, multivariate analysis. Male gender and late night arrival were associated with intubation. So again, it could be provider dependent. When you show up and a nocturnist is there, or it's less amount of people to watch them, or some sort of operational situation at the emergency department that has nothing to do with clinical medicine. Less coverage, so we intubate people. Um, those were people getting intubated. Maybe the newer docs work at night. Who knows? But neither ketamine dose, co-administration of sedation, additional meds, evidence of alcohol or a sympathomimetic, cocaine, MDMA, ecstasy, things like that, was associated with intubation. So again, it's not additive to the other meds. Either high dose ketamine greater than 5 mg per kg or co-administration of midazolam or Haldol was associated with intubation in the logistic regression analysis of the patient. So again, all these things we think about medically, confounding meds, other co-administrations. What was mattered was when you showed up and whether you were a guy. That's how they had people more likely to be intubated. And the p-value there, the late night arrival is less significant, but the p-value for male gender is high. So it sounds like the more excited delirium patients that were men got intubated. And this one also says a high degree of provider-dependent variability, meaning Dr. Barber intubates everyone, and Dr. Barber doesn't intubate everyone, which is tough to take where the medicine impacts your clinical guidance when it's just provider dependence that ends up being this post hoc outcome, which actually we see at the city because one hospital in particular says ketamine is bad. Last one. For those of you who may recognize some of the names there, but Matt Friedman is a former FDNY fellow. He works at Maimonides and an overall good guy and a huge proponent of ketamine in our region. And I actually had him look at our slides prior to today and got a blessing from the guru. But Matt went to one of these, they have an acronym for them, but EMDF or EDMF, Burning Man, that kind of stuff, right? Modern Woodstock, right? But he enrolled people at this large EDMF festival over these 8 days on 2 consecutive weekends. So 40,000 people per weekend, on-site medical tent, just like a marathon or any other type of event medicine. EMS providers, nurses, emergency physicians. This was not going to be 2 EMTs in the tent. This was there's a full MASH unit type mobile hospital thing. 275 people of the 1,000 that had their charts recorded had a chief complaint of AMS. 68 had severe agitation and was treated with dissociative dose ketamine. So single dose, 4 milligram, quote unquote, the high range. And then the mean initial dose was 308 milligrams. Michael Mina, I am not at liberty to say which festival it was. But I give Matt credit for getting published in a major recognized journal and getting the word festival as part of the part of the decisions there. But yeah, mean initial dose was 308 milligrams of ketamine. So basically, you're in the tent. Someone comes in, young person, hot and bothered on a summer weekend, and they're getting 4 mg per kg of intramuscular ketamine, and they quote 4 serious events. For 6% of all patients. 2 patients had copious hypersalivation treated with atropine. Again, physician on scene with long-term monitoring. So back to I forgot whose question it was about the hypersalivation, but you can do it. I don't say I'd do it, and it certainly wouldn't be something I'd protocolize. 1 patient had transient apnea requiring assisted ventilation, and 1 patient was intubated and transported to the hospital. 42 patients, so a little more than half, required a redose back to the dosing time frame, the 5 to 10 minutes versus the 25 minutes. So it takes them about an hour maybe to sober up and calm down. And they basically from that, I would say you should expect to think about giving another dose if you're not getting rid of the patient within 30 minutes. And then this is just like they should put this on just etch this in stone. This is great. All patients who received ketamine, except the one who was intubated, were sent back to the festival, meaning the apneic person who got assisted ventilations got sent back into the mosh pit, which is just fun for me. That being said, that I think this was great because this was, one of our local New York City docs who's familiar with ketamine, and Matt actually helped push forth the ketamine, integration at the city. So this was his firsthand experience of using it in that type of rave type situation. Anyway, that's all in the journal articles. I'm going to leave you with this picture of the ketamine kid getting his dental work, and make you also think of not getting into a K-hole. Anyway, I'm done. That was a quick hour. I'd like to open it up to everyone. I'm going to take it off presenter mode and have anyone ask your questions away. Just unmute yourself, maybe raise your hand, and I'll call on you. I hope everyone heard me. Oh,
hey, Dr. Barber.
Kevin,
Paul.
Go for it.
Hi,
Go ahead,
good
Kevin.
morning.
You got the floor.
Yeah, you can hear me. Just a question about ketamine. Is there any retrograde or amnesia associated with this drug?
The key that people bring up is that they're in a very stimulated situation. Do they remember it? I'd have to talk to some people who use ketamine, but they're definitely reacting to you. They're just not aware what they're doing.
Mm-hmm.
I've had some people say things they didn't think they were going to say in front of family members, and it gets, unique, but they don't remember it because they're not really aware of it because of this dissociative piece.
Okay.
All right.
Thank you.
No, good question. We use the propofol with it for the amnestic piece, but that's more of, being humane. I don't care if they remember the EMS trip or not. I mean, you're in an austere environment. We're pushing for safety to them, safety to you. I don't think you should be identifying like I need to give a benzo with this so they don't have a bad trip. I also think once they're in excited delirium, the idea of having them, avoid the quote unquote K hole, they're already in it, and what you're doing is trying to get them to safety. We have 80 people with their hand up. Holy, that can't be. Who else has a hand up? Paul Darawanda, you have the floor.
Yeah, so Dr. Barber, so going back to that, the ketamine drip, I wasn't specifically referring to a ketamine drip, more so just making a concentrated ketamine, which we're looking at 100 milligrams per cc, into something in that low dose range for the pain management, where the max is only 25 milligrams, to make it into like a 1-to-1 concentration, 1 milligram per 1 cc, just so for ease and accurate administration, because it's such a low dose that we're giving.
Sure. I think mixing a concentration prior to administration would give some quality people a stroke. And I would say we don't want you mixing the drug, even if it means making it safer. Does that make any sense?
No, yeah, totally. I got you.
It's a wide variety of providers we have on the road. I think, we try to get the epi drip in and, other things like that. But I think what we have to focus on from a quality piece until we really get familiar with it is, this is the medicine, this is how we're going to pull it up, and this is how we're going to give it. So from, like I said, from an oversight perspective, I don't disagree, but it makes the hairs on the back of my neck stand up.
Well, I totally understand you. I got you.
Does anyone have any anecdotes they want to share? Andrew asks a good question. Outside of hemodynamic concerns where ketamine could be advantageous, how would I decide when to give ketamine over the other medications we have for each subcategory? So I think that's an interesting question. I'm not familiar enough with the other reasons why you would be thinking of this. Ketamine comes to me as essentially procedural sedation only. If you wanted to use ketamine for pain, I think the patient in that situation would be maybe an opiate abuser or someone with a lot of somatic type symptoms. Euphemistically, I'm trying to paint the picture of someone with a lot of, behavioral / pain issues, a lot of chronic pain syndromes co-mixed with like depression and stuff like that, where the patient may be tolerant to some meds or tolerant to other things. Or you mentioned, I have Tylenol, and they go, what the hell is wrong with you? I'm not going to take two Tylenol. Like some, person who's maybe tolerant to other methods of therapy. I don't think it would be the best bet for the person who is amenable to a shot of ketorolac or Tylenol or some morphine, but types of intractable abdominal pain, other types of things where the medicines that you have aren't maybe aren't the best bet. I think opening up the idea of giving ketamine for pain is great there. I would note the dose is going to be tough to pull off with the concentration we have. So I would defer to our operational leadership, whether we want to start stocking, 1 ml syringes or something like that. But I think that's something that we have to come together with. But that type of population might be the best for the pain. With regards to delirium, I mean, I think ketamine is really the best to go. I am not a fan of the Versed 10 at all. With regards to intubation, I think you should. I think you guys should use it and tell me what you think. I mean, I think the concept of 5 of Versed to take someone down for intubation is really suboptimal. I'm a fan of etomidate. I mean, I think you guys could identify different practice patterns, maybe etomidate up front and ketamine to follow versus the Valium. But I think we're in a learning curve for all of us, and I'd be happy to hear your feedback about it because the protocols are becoming wide open. There's a lot of changes. It's tough to say, one specific thing. Ashley, you have the floor. Sorry, Evan Ashley, you have the floor.
Hi, Doc. Hi, guys. So I have an anecdote about ketamine.
Bring it on.
So a flew mission on Sky Health, Peconic Bay to Southside. Not Southside, Stony Brook. Gentleman was assaulted with a machete and had a massive infection in both of his arms. Was a poly substance abuser and a opiate addict. And we got to him, and Peconic Bay had just gotten an IV on him. And my partner and I were discussing what we could use for pain management. And we came to the decision, because the patient screamed at us that fentanyl didn't work on him, to use ketamine. So we gave him, I think it was the protocol we used was 25 milligrams of ketamine for pain management, which worked wonderfully. And then en route, he actually had
IV or IM?
IV.
Okay.
And during the transport, it seemed like he had what could have been classified as an emergency reaction. And he started to wake up and get up, and was trying to get up out of the stretcher. So we gave him another, I think it was 25 milligrams. It might have been a little bit more. I don't remember exactly, but he went right back down. It works really well for pain management, especially in that patient population who's habituated to opiates.
Mm-hmm.
From
so
what I
see, you were in that, and again, these are not weight-based doses, but you were in that 10 to 30, which was somewhere between pain and recreational, which You could have went a fully dissociated him, but since it's an undifferentiated patient, a poorly differentiated patient with multi-organ situations going on, and I haven't heard the word machete used too frequently, so it sounds like he was a unique case. But I think that was great, and the redosing may be something that is a key point for everyone to understand that it may work, but it's not going to be a forever. And that's why constant monitoring and vital signs is key. Did anything happen with the hemodynamics? Did you see the heart rate go up a bit?
He was pretty septic as it was, so his hemodynamics didn't really get affected all that much. He may have gone up a little bit in his blood pressure, but not really anything significant.
Sure.
He stayed pretty stable.
So, like I said, we do see the blood pressure go up, but we know that if I give you prednisone, your white count goes up. And part of being a good clinician is understanding what's expected and what's not. I don't see heart failure like I used to. I trained in downtown Brooklyn, and heart failure was like, oh, it's heart failure. And now when I get a heart failure patient, it's like, doctor, the blood pressure is 220 over 120, and I'm like, woohoo, let's go, nitro baby. Like that's good. It's when the person's in heart failure and they're 110 over 70 that I'm like, oh Christ, what are we gonna do? Because when I'm going to give that nitro to preload reduce that patient, I know the blood pressure is coming down. So I'm happy with that. So if I saw a patient and gave ketamine and the heart rate didn't go up, I would actually ask myself, is it working? If I didn't see the fasciculations at the eyes, the fluttering, the dentistry kid, is it working? Did I give enough of a dose? So knowing how your medicine acts is really the key to deploying it in the best usage. We're going to do a quiz after. It doesn't look like anyone has any other questions. We're going to do a quiz post attendance. I admit we haven't written it yet, but I think it was great to get all your feedback. There was a lot of feedback on the forums. I tried to catch as many of them as I could. Is there anything that we did not cover at this point for ketamine that you feel important? If you want to Teams me privately and not have your name show, that's fine. But everyone here is invested in learning about this medicine. I'd like to catch any additional learning points. No. Anyone? Jacob Stebble has a good question. Ketamine and intubation to preserve a neuro exam. So ketamine versus a paralytic, you're going to get the reflexes at least. But I think that's very altruistic of you to think about preserving a neuro exam. I wouldn't make a decision whether you're going to choose one med or the other based on that. We're going to do a bunch of CAT scans anyway, so it doesn't matter. I mean, neuro exam is like something the students do at this point. Brian asks about interest of possibilities in EMS studies for use of ketamine. Well, what questions are we going to answer, Brian? I mean, we're going to answer. If you want to unmute and talk and discuss, I'd be more than willing to give you the floor. But
yeah, my thought on that is, if you're saying that you're looking for feedback from the EMS field, and this is right on the cusp of understanding this drug and how it works when it interacts with patients, it kind of seems that that's a great place to start a study for EMS.
I think the purpose of a study would be for everyone on this call and then some to get the information on what's going on. Like this happened and that happened. So I think an anecdotal share would be great in some sort of PHI sensitive fashion. So, I'd be willing to, if everyone had an indication or had something that they wanted to talk about, it, we could re-engage the ketamine crew But for now, it's so many uses to say it's a research study might not be something that's achievable. But I do think knowledge sharing would be the what's really vital. Like, and I think you guys should be sharing this amongst yourselves. Hey, I gave it for intubation. It worked great. I gave it intubation and it didn't work. I think the key that maybe Andrew brought up earlier is person who's never had this medicine, who's in distress, might be the best. Might be the best player. Anyway, I don't really have anything else for you all. I'm happy to give you back 40 minutes of your day, but I will leave you all with this. I don't know if it's going to play. Let's see. Oh, yeah. That's the Millennium Falcon at Hollywood Studios, which I did go to earlier this spring. Anyway, may the 4th be with you all. Star Wars and Star Trek jokes aside, I hope you all had a good CME. And ketamine. Oh, Kevin Pantaleone is good. Ketamine is safer than etomidate as an induction agent to avoid peri-intubation arrest. If you're thinking about that, I think it's worthwhile to give it a shot. It is going to be a disaster situation. I would rather you reach for some push dose epi as opposed to choosing ketamine over etomidate. But I'd rather you normalize the vital signs before you give them anything. But yeah, it's true that ketamine's probably better. I don't think we have that side by side data yet, though.
Thank you.
Michael Mina says, "Are we allowed to give push dose epi?" I thought we were given that yet. We're not giving push dose epi. They didn't give me that one yet. It's probably in a coming protocol because I put it forth for respiratory arrest that you could give peri-arrest intubation, peri-arrest epi. Yeah, I may have spoken out of turn. That's coming down the pipeline. But peri-intubation arrest, we want you to normalize the vital signs. So in the absence of that, Kevin's question at the end there is the big piece here. If you only have ketamine versus etomidate in a peri-intubation arrest, you should absolutely use ketamine. How's about that? Listen, for those of you who know me, RSI would be in your hands already. I'm trying. Just got to get all the votes coordinated. I feel like Lincoln trying to pass the amendments here. You got to buy and sell these votes from people to make sure that they're all getting taken care of. But RSI is coming. The peri-intubation arrest meds are coming. And listen, everyone have a great day. Be well, be safe, and enjoy the nice sunlight. All right, I'm going to sign off, and I appreciate everyone. Take care.